Thank you, Dr. Harshal, for inviting me in this instruction course, and a very good afternoon to all of you. I'll be talking about the basic preliminary things that we should be aware of regarding toric IOLs. And I have no financial interest with the subject matter of this presentation. The question is that what's the need of toric IOL? Well, earlier, and maybe 5-10 years back, we never implanted toric IOL. The patients were still happy. But the fact still remains that nearly 29%, a major study says 29%, otherwise there's a range of studies which says that nearly 20 to 30% of patients who do undergo cataract surgery, they have significant astigmatism, and that needs to be corrected. And that is more than 1.25 diopters. And 10% have 2 diopters or more. Now, why it needs to be corrected? The basic reason is this, that the crispness of vision comes only if you don't have astigmatism like this. Otherwise, if you have varying degree of astigmatism, the crispness of vision goes away. So, a patient who has a significant astigmatism, anything more than 1 diopters these days people consider. Even for 1 diopters, yes, there are models which correct for 0.7 diopters of the corneal plane, and then nearly 0.2 to 0.25 is the spherical equivalent, surgical induced astigmatism. So nearly that also is corrected. So anything above 1 diopters, earlier it was 1.5 is cut off. Now anything around 1 diopters can be an indication for toric IOL implantation. Astigmatism which is of a regular type, regular bow tie pattern, then toric IOLs are quite useful in cases of keratoconus with no progression or significantly negligible, negligible significantly in terms of progression. Then post-keratoplasty eyes only after removing all the sutures. If you still have astigmatism and it remains stable for some time, then one can do that. There are certain conditions in which premium IOLs should not be implanted. Any condition which involves corneal pathology like Fuchs, stromal dystrophies, in all these conditions we should not implant any premium IOL. And the same holds true for toric IOL. And patients who have potential capsular bag instability, that is pseudoexfoliation or zonular deficiency, these may be considered unsuitable, although some patients have pseudoexfoliation wherein if you feel that there is no significant any of zonular dehiscence, any evidence of zonular dehiscence, you may implant an IOL. So it comes as a relative contraindication. Some people like to put a capsular tension ring and then put a toric IOL in cases of pseudoexfoliation, so that they can strengthen the bag, stretch the bag. Now, so the patients needs to be thoroughly evaluated for toric IOL. So what all we should know? The toric IOL cylinder power is basically based on the corneal astigmatism. So that needs to be taken care of. Then as far as astigmatism is concerned, the manual keratometry is still considered as the gold standard, although there are studies which have shown that automated keratometry or IOL master or Schumfling imaging, these are quite good, but still in most of the researchers, they prefer manual keratometry. Now, there's a Cox study which was done in Baylor, and they found out that in spite of doing correction for the anterior corneal astigmatism, there is still some amount of ghosting of images, or there's still some amount of uncorrected astigmatism, and that is probably because of the posterior cornea acting as a minus lens, and it affects the astigmatism. So a general rule was formulated that the posterior corneal cornea has an astigmatism of nearly 0.5 diopters against the rule. So if you have with the rule astigmatism of 1.5, so you can reduce it by 0.5 and consider 1 as the effective with astigmatism. And if you have against the rule astigmatism, then you can add the same amount to have the final effective astigmatism. The IOL power calculation is done by the standard formula. The spherical power is calculated by the standard formula for that eye, which we use. And then by different toric calculators, we calculate the the amount of astigmatism, amount of toricity, and the axis. There are various toric calculators available based on companies. We at RP Center have the maximum exposure to the Acrosoft toric calculator because we keep implanting these lenses. So these are also quite accurate. They give you the toric IOL model and the axis to be implanted. The data that you need to put in is the preoperative manual keratometry, IOL power, that is the spherical power, the incision location, and estimated surgical induced astigmatism. Now, this is the software wherein you just put in the flat K, the flat meridian, steep K, steep meridian, spherical power, surgically induced cylinder, and the incision location. Now, incision location basically is understood by this diagram. If you are doing a temporal incision making in the right eye, it is 180 degrees, and if it's in the left eye, it is 0 degrees. And surgically induced astigmatism is the astigmatism that is caused by the incision and the manipulation through the incision. So it has both power as well as the meridian, the vector. So it has to be calculated based on this software that is available. This is the website that is available, www.drhill.com. The data that you have to enter in is for surgically induced astigmatism is state of surgery, the eyes, the prior corneal surgery, whether it was done or not. Incision location, very important, as I showed. Incision type, whether it's clear corneal or others. Size of incision, pre-op K1, K2, pre-op axis 1, axis 2. Then post-op K1, K2, post-op axis 1, axis 2, and then you just have to enter create, and that creates your surgically induced astigmatism. Now, if you have not created your surgically induced astigmatism and you are using a 2.2 millimeter blade, so majority of the surgeons have their SIA between 0.2 to 0.3. So you can consider putting 0.25 diopters as your surgically induced astigmatism if you have not calculated yours. And there are certain issues like for calculating the surgically induced astigmatism, you should use the same instrument for entering the data, because this was data of one patient, right? This was data of one patient, and similarly you keep putting data of say 100 patients, 1,000 patients, and then you get an average of that. So that gives you your SIA. So it takes some time for actually calculating the SIA. Manual keratometry, as I told, is considered. And axis measurement has to be between 0 and 180 degrees, and it should be a regular astigmatism. That's how you calculate. Now, this is the toric calculator as I showed you earlier. So you have to enter these data along with your surgically induced astigmatism and the incision location, and then you get all these things. Like this is one of my patients. So you get the toric IOL model, you get the IOL power, spherical power that you get. Then you have the axis of placement, the power of the cylinder, and that is how you get it in the IOL plane as well as in the corneal plane. So that gives you the basic idea that what to be done. There are various toric calculators. This was Acrosoft toric IOL calculator, which we have found out to be quite accurate. Then you have the iTrace toric calculator by Hoya, and that has also been considered to be quite comparable. Then you have the Barrett toric calculator, and then you have the Technis. Barrett toric calculator also incorporates the effective lens position, and then you have the Technis toric calculator. So all these companies have their own toric calculator, and majority of studies have found out they are comparable. There's a recent study published which has given Barrett's calculators a slight edge over other calculators, but that is also to the not to the extent of significant astigmatism, residual astigmatism. So you can use any toric calculator which you are using, and that takes care of it. There are so many toric IOLs and calculators available, so there are so many models, and there are various types of IOLs that are hydrophobic, hydrophilic, all sorts of IOLs. But the best thing, as we all know, is the hydrophobic IOL that we should implant, because it sticks to the capsule. So the only problem that we can have after implanting toric IOL is the rotation of IOL. And if the IOL sticks to the capsule nicely, as we see in hydrophobic acrylic IOLs, that should be considered as the IOL of choice. Thank you very much.